Okay, I'd like to introduce Jim Goodin, the President of the Mental Health Foundation of Victoria. Jim has had a long association with mental health, both in Victoria and nationally. Jim's the former President and Secretary of the first support group for OCD, which was established in 1987, and he's had a keen interest ever since. And Jim has had close association with hundreds, if not thousands, of people with OCD. So we look forward to Jim's presentation. So thank you.
Thanks, Carolyn. That's very kind of you. Oh, well, we have a small but intimate group today, and everybody's introduced each other, I think, to everybody else. So that's great. And I have a very lengthy presentation. What I've actually done is I've sort of joined three big presentations into one. So I'm going to try and cover a lot of ground, but I don't want to deal with things that you're not interested in. So if there's something you're not interested in, let me know. And if there's something you are interested in, tell me that, and I'll spend more time on it and I'll go through it. I'm happy for it to be flexible and for it to be, well, interaction, if you like, and you tell me what you like, etc. So, vast amount of territory. So let's talk about this interesting and fascinating condition, but unfortunately very destructive condition of obsessive compulsive disorder. We'll just see that things work. No, that's a good start. There we go. I think this is an interesting comment from a sufferer of OCD, J.J. Keeler. OCD is not a disease that bothers, it's a disease that tortures. And we no doubt have some people who suffer from obsessive compulsive disorder in the audience, and you'll well know what I mean and understand by that. And I think I'll make that case as we go further on. Sigmund Freud said this is a mad disease, surely. I don't think the wildest psychiatric fantasy could have invented anything like it. And if we did not see it every day with our own eyes, we could hardly bring ourselves to believe it. And Freud was quite interesting in his early observations of obsessive compulsive disorder. He related it to sexual dysfunction and poor potty training and all sorts of interesting things that we've certainly grown past. We have some much more sophisticated explanations about obsessive compulsive disorder, and I'll certainly talk about those later. The French called it la folie de deux, the doubter's disease. It's a chronic psychiatric disorder, one of the 10 most disabling medical conditions worldwide. Now, that's a remarkable fact in itself, that it is one of the 10, this is from the World Health Organization, the global burden of obsessive compulsive disorder in the year 2000. It's actually in little writing under that label. It's the fourth most common psychiatric disorder, and it's not received the due attention that it really warrants, given its destructiveness and the pain that it inflicts on people, because it's really can be a hidden condition. People with obsessive compulsive disorder can hide it away very effectively for many, many years. It's categorised through the Diagnostic and Statistical Manual 5 as something, or the obsessions, as recurrent and persistent thoughts, urges or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or stress. Well, I would say all individuals that experience them. The individual attempts to ignore or suppress such thoughts, urges or images, to neutralise them with some other thought or action, such as performing a compulsion. So that's one half of OCD, if you want to think of it as that. The second half of the compulsions, the repetitive behaviours, e.g., as it says there, hand washing, ordering, checking, or mental acts. For example, praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviours or mental acts are aimed at presenting or reducing anxiety or distress preventing some dreaded situation. However, these behaviours are not connected in a realistic way with what they are designed to neutralise or prevent, and are clearly excessive and realised as being excessive by the consumer too. The important thing, by the sufferer I should say, I'm using the word consumer. The important thing to realise about obsessive compulsive disorder is that compulsions can exist separately to obsessions, and a patient might have only compulsions and they might have only obsessions. As far as the classification, recently obsessive compulsive disorder in this new DSM-5, which came out 3 years ago, originally before DSM-5 it was classified as an anxiety disorder. It now falls into a completely different classification of its own. It's now classified as obsessive compulsive and related disorders. It used to be in the anxiety disorders, which you can see above here. Anxiety disorders, the new classification, obsessive compulsive and related disorders, and the various forms that it takes, which I will discuss in a minute. So just to fill you in, some conditions have changed categories. For example, post-traumatic stress disorder used to be up here as an anxiety disorder. Obsessive compulsive disorder used to be up here as an anxiety disorder, and selective mutism used to be classified as an adolescent developmental disorder, and that's now in the anxiety disorders. The idea is, it's like a chicken and an egg. Which comes first when we're talking about obsessive compulsive disorder? Does the anxiety produce the OCD, or does the OCD, the obsessive compulsive disorder, produce the anxiety? And it's really accepted now, because of all sorts of interesting scientific and neurological research, that the obsessive compulsive disorder really produces the anxiety. And of course we know what happens if you're anxious for too long. Anyone suggest what happens if you are anxious for a long time, become stressed, anxious? Ultimately it will lead to depression, and depression is of course a much more severe issue than anxiety. I'll just move on. All right. Some of the nature of obsessive compulsive disorder, well, we've got 200 OCD patients here, and you can see the breakdown in terms of the sorts of things: contamination, sense of pathological guilt or doubt, disgust with bodily functions, need for order and symmetry, aggressive feelings, and mainly fearful feelings that they might have hurt somebody by something that they have done inadvertently. Sexual obsessions. They might obsess about the shape of somebody's buttocks or breasts or something. And many people have multiple obsessions. And left untreated, unfortunately, obsessive compulsive disorder can globalise. So you might start off with a particular type of obsession, and then other things might come on top, and you have this kindling effect. Compulsions, well, the most common image of an obsessive compulsive is of course somebody checking or washing their hands, but it can take other forms like counting, asking, confessing to crimes that you did not commit. Symmetry, precision, compulsion, for example, if there's a plaque sitting on one side of that screen, that there should be something to counterbalance it sitting over here, and the fact that there's not would just drive me crazy, you know. If I had obsessive compulsive disorder, which I'm going to share a little secret with you because you're such nice people, I do have obsessive compulsive disorder. So I can talk about these things, and I can talk about these treatments as somebody that's experienced them firsthand. And that's just our little secret. You're not allowed to tell anyone in the room, and just because that camera is filming me and it's going to go global in about 3 weeks, we won't say anything. We'll just pretend I didn't say that. All right, obsessive compulsive disorder and related disorders. There's a very complex chart, and I don't really want to go into it too much, but you can see that there's a lot of overlap between all sorts of mental health conditions. The ones in green are the most interesting as far as I'm concerned. Certain disorders like body dysmorphic disorder, which I'll talk about more, Tourette's syndrome, which is a fascinating condition, chronic tic disorder, eating disorders, and major depression. You can't live life as someone with obsessive compulsive disorder and not suffer from major depression, ultimately. It just wears you down. It just tears you apart, as you're probably aware. I see some people nodding their heads. They know. But the interesting thing that I'm going to present to you is that there's a great overlap between obsessive compulsive disorder and motor disorders. Disorders like Sydenham's chorea, which was once called St Vitus dance. Conditions like, as we say, chronic tic disorder, Tourette syndrome. Conditions that have been demonstrated neurologically to be affected by a particular part of the brain called the basal ganglia, which is a very deep structure, deep down in the brain. And I'll talk more about that. But it does seem that there's quite solid evidence now to indicate that the kind of damage, take that word, damage, that creates obsessive compulsive disorder also overlaps into these kind of motor control disorders. Damage in the basal ganglia. That'll be a central part of my thesis tonight anyway. So what's the manifestations of obsessive compulsive disorder? Well, running a support group for many years on obsessive compulsive disorder, as I once did, I was always amazed at how many people came to the groups and they were absolutely traumatised because they thought that they might have hit someone on the way over driving their car. And they might have driven around a particular block or a particular circuit 4 or 5 times in the belief that they had to go back and check and see whether or not they had hit somebody, that they'd find a body lying on the side of the road and they'd be looking for the body on the side of the road. They'd check their cars to see if there was any impact damage from the body. Intrusive thoughts that they might endanger someone else. They might have a terrible thought. You can see this terrible image of, pencil, somebody stabbed through the eye. Now, not that they would actually do that, but they might fear that terrible image and that be an obsession, that image, and they couldn't control that image in their own mind. Most people could get rid of it, could say, I don't want to think about that. That's a ridiculous thought, and they could turn it off. A person with obsessive compulsive disorder would find that, or could find that kind of image very, very difficult to turn off. The urge to shout out an obsession or blasphemy, for example, in a church. And this was someone I knew called Vince, and it could only be suppressed by him counting slowly backwards from 100 to 1. And this is interesting again because it indicates an overlap with a condition called Tourette syndrome, which I mentioned earlier on, and two aspects of Tourette syndrome that are very common. One is echolalia, that is the wish to repeat something or to say a prayer or to make a statement, and this statement might be made over and over again. And the other thing can be coprolalia, which is involuntary swearing. And so you'll have children and adults with obsessive compulsive disorder, Tourette syndrome, and they'll come up to you and they'll say, fuck you, and then it'll be such pain that they feel forced to say that. And they'll blaspheme. And the overlap between this OCD and Tourette's is quite profound, quite profound. Obvious thing, showered 64 times today, hope no one will notice. All sorts of, you can see neatness rituals that someone might perform. I won't go into the details of that, and I'll talk more about the OCD measurement scale shortly. This is typical of the sort of exercise that someone with OCD might indulge in ordering their food. I spoke about movement disorder, stereotypical movement disorder of arm flapping, this sort of thing, or it might be one arm. This is a very common manifestation of obsessive compulsive disorder, Now, why is that? If there's not some kind of effect or movement disorder involved. And as I say, number one suspect and culprit, basal ganglia. Hand bouncing is another common thing that people will check like that, or they'll bounce their hand, and then they might have to do the same number of times with the other hand. And there's sort of a feeling that, I don't know, that maybe it's not really checking, it's really about symmetry of the hands. But it's still movement that's involved. Okay, another impulse, eye fixations. The urge to look somewhere that's inappropriate might be to look at a woman's legs or her breasts or her buttocks, or for a woman to look at a man's crotch, or I don't know, some other part of the body, or to look somewhere where you know you shouldn't look. And for many people with obsessive compulsive disorder, that can be a very difficult thing. Blinking, rolling eyes, peripheral vision avoidance, not wanting to see things on the edge of your vision because that's distracting you, and there being a tremendous urge or impulse to turn your head in that direction and focus on that image. Hoarding is one of those interesting subgroups of obsessive compulsive disorder. And let's just have a look at hoarding disorder, because it has become quite well reported and popular recently. People cannot part with acquired objects. Most of the objects are worthless. People become extremely attached, and they're resistant to relinquishing objects, and it literally causes physical pain to do so. Many are unaware of the problem. Lots of people indulge in animal hoarding, and we've seen some notorious cases on news networks of that recently, and the consequences, of course, very squalid living conditions and affects relationships very, very badly. Body dysmorphic disorder, another very interesting condition where a person can be preoccupied with an imagined or exaggerated defect in their appearance. Whatever it is, it might be an aspect of just a regular aspect of body feature, or it might be a blemish or pimple or birthmark, or could be anything. It could be literally the way their hair folds across their head, and they could see that as some way a defect, and that will, because of their obsessionality about it, it can drive them out of their skull. They'll check their appearance. They'll try and camouflage their appearance. Some people indulge in plastic perform plastic surgery to rid themselves of moles or blemishes or perceived defects. So it can overlap with self-mutilation. See the overlap between these conditions that I'm making once again. Sometimes it's very hard to draw the line and say what's what. Great levels of shame, anxiety and depression associated, as I say there, more often associated with women. Interesting fact that 5 to 7% of women seeking plastic surgery, it's estimated, and I would say probably a higher figure than that, probably suffer from a form of body dysmorphic disorder at least. Compulsive hair pulling, trichotillomania. I just throw this out there for you. Is this some sort of grooming ritual, instinctive grooming ritual gone haywire? Is this in some way somebody trying to adjust their behaviour or make themselves fit some kind of obsessional, idealised vision of themselves? I don't know, but I throw that out to you. Another very interesting one, excoriation or dermatillomania, where people will pick at a perceived defect. It might be a pimple. It might not be a pimple. It might be just a feeling that the skin is irritated in some way. Now, I'll throw out a proposition to you. Is this, you've seen primates in the wild delousing other primates. Is this maybe a continuation of that sort of impulse in us as human beings, but gone awry? And I'll talk about that more later, because some of the evolutionary anthropological implications of obsessive compulsive disorder are actually very, very interesting. I say it's an interesting disease, but it's not interesting to have. And of course, childhood OCD is very, very destructive and painful to watch. As it says here, OCD is like having a bully stuck inside your head and no one else can see it. And that's very true. That is the sensation, the internal experience that you have a bully, or you have a power or a force in your head that is acting separately to really your conscious mind, forcing you to think and feel certain things that you don't want to think and feel, and do certain things that you don't want to think or feel. So it's almost like having an unwanted person in your head. And of course, bad thoughts cause torture, especially for young people. Let's just quickly talk about childhood OCD. The same sorts of things apply, but imagine them in a particular context of going to school, for example, where a child might have to walk 3 times around the classroom before they can sit in their chair, and maybe 3 times back the other way before they can sit in their chair, where they must have their shoelaces of exactly equal length, otherwise, you know, they keep doing it until they get it right. Even if it's only within a millimetre or half a millimetre of being correct, it might not feel right. These sorts of things result in the child being, you know, victimised and bullied, etc., and seen as being different. Or the child that, simply like a magpie, must fly back and pick up a stone or an object that. I see people nodding. Yes, you're one of our brothers. A very unfortunate condition as far as that's concerned. What's happening with OCD? Well, this is the first line of evidence, I think, that really indicated that there was something going on neurologically with obsessive compulsive disorder that we did not understand but was measurable. It wasn't just strange neurotic behaviour, if you like, that there was some chemistry that was aberrant and going wrong. And these were the early PET scans, particularly from the 1990s. And I actually underwent one of those in those days, in 1992 at the Austin Hospital, and as a part of a whole group of people. And this wasn't the particular study that I was a part of, but what they found, generally speaking, remember, if you're taking hundreds of people and you're getting the collective results, what they found in the normal controls, if we imagine that those yellow areas are where glucose is being burned, metabolised in the brain, the PET scans show the areas where glucose was being most concentratedly metabolised in the brain. And you can see in the normal control, there were certain hot spots, if you want to put it that way. Look at the person with obsessive compulsive disorder. Now, this was the same situation where you were put into a PET scanner, you were asked to just be yourself, don't think of anything obsessional, or don't think of anything abnormal, or perform any rituals or whatever. And this was the difference to that. That was normal. That was with the person with obsessive compulsive disorder. Now, this really was the first hard evidence that there was something very interesting neurologically going on. But of course, people would argue, well, is this a cause of obsessive compulsive disorder, or is this an effect of obsessive compulsive disorder? In other words, do you have that brain abnormality because of the way that you feel, or in fact, is that somehow causing the feelings? Now, it depends on, it's a horse and cart sort of argument, and I think it's a bit pointless myself to go down that track, but it's an interesting thing, and it basically accounts for the disagreement between psychologists on one hand, behavioural psychologists, cognitive psychologists, etc., and psychiatrists, the medically based opinions. I don't want to argue one way or the other. I have my own bias, which I've probably made clear to you already. but the psychologist would probably say, well, your behaviour is causing this aberrant brain chemistry. The medically oriented person would say, no, that aberrant brain chemistry is causing your behaviour. They would link it back the other way. From a neuroscience point of view, there's no argument. It exists, it's there. The abnormalities are there and they're quite measurable, and I can quote them ad infinitum. However, that doesn't mean that they are the only medical treatments, psychiatric treatments are the only treatments that work. As it says here, there's all sorts of ways you can deal with this. You can go down the biological path of using medications and medical treatments. You can go down the path of using psychological treatments. Social aspects, of course, you know, can be very important. Changing your lifestyle can be very important too. There are many ways of dealing with obsessive compulsive disorder. What works for you works. That's the important thing. It doesn't matter if it doesn't fit a particular view that somebody else has. Possible causes of OCD, well, I'll just quickly list them. Biological, familial, that maybe there's some attitudes and experiences that have been learned in a family setting. I'm very interested in the environmental causes for the reasons I'll talk about later. Are they related to physical injury, particularly of those structures that I mentioned earlier on? Insufficient serotonin. There's certainly in the early 2000s and late 1990s, there was, you've all heard of this wonderful neurotransmitter serotonin and the serotonergic theory of depression and OCD and just about everything else. Well, it's a lot more complicated than that, as it turns out. Emotional trauma. Was it some severe emotional upheaval? Did a parent hit you? Did a parent abuse you in some way? Did that perhaps cause obsessive compulsive disorder or leave people predisposed? And another area that I've left totally separate, I've talked about infection, because there is some very definite evidence that infection, particularly streptococcal infection, bacterial infection in children, can be responsible for, or can be implicated, rather than, I won't say responsible, I'll be reasonable, I'll say can be implicated in an obsessive compulsive disorder. But I will show a picture of somebody that is an expert in this area and what her perspective is. Let me just show you what can happen when a child has an inflammation of the basal ganglia, for example. During the episode, if they're asked to draw a picture of a woman, they'll draw a picture like that. This is what they drew before the infection, okay? After being treated with, and by the way, this was they had obsessive compulsive disorder. PANDAS, as it's called, rapid onset obsessive compulsive disorder. And they were asked to draw a lady during the episode and after treatment with simple antibiotics. And this was the result. There's some evidence to suggest that while antibiotics might work in young children when there hasn't been a particular amount of brain damage, but in adults, probably giving them antibiotics is too late. Probably whatever infection they had, if it wasn't treated, has caused permanent damage neurologically to certain structures of the brain. I think I jumped one there. Did I jump one? Let me just check, sorry. Ah, yes, okay, because I do want you to see this.
We'd like to welcome you to the Northeast PANDAS Parents Association.
This is Susan Swedo, who's an expert in this area, talking about PANDAS, or streptococcal caused or implicate.
We'd like to welcome you to the Northeast PANDAS Parents Association first conference ever. There's three goals for our association. One is to provide an opportunity for parents to meet and come together and see that you're not alone. You're not.
All right, I can't get it to the point where I want. Well, I'll give you the extra 1 minute 50 because I think listening to Barbara Swedo talk will be very illuminating. I'm trying to hurry it through, but I think we should hear the whole thing. This is about this streptococcal infection in children, which I think is very important to hear.
Isolated, that there's a lot of us. And another goal is that we help the medical community and the clinicians that are trying to help our children. They are working tirelessly day and night, the majority of them, and are really trying to help us. And so if there's ways that we can help them, we want to be able to do that, not just today, but moving forward. And we'd like to try to expand the quality and treatments. There are people here from over 30 states and Canada, and there's over 100 doctors here from different states from across the country. Collectively, in this room, we have spent over $3,309,550 to try to get our children well. I have the true honor of introducing our next speaker, Diana Pullman. Diana started Pandas Network in 2009 when her son became ill, and she has spent the last 5 years helping desperate parents find answers, connecting doctors and researchers, funding research, and promoting PANS and PANDAS awareness throughout the country.
There is a tsunami of need. Our needs as families have far outreached the medical community's recognition. This is a grassroots movement. We're continuing to try to get doctors to meet each other. Actually, Tanya Murphy and Dr. Beth Lam or other doctors had expressed that often parents don't have any material about PANDAS when they go into doctors' offices. So we created first ever brochure on PANDAS. So when you're a new patient in a doctor's office, you have a little bit to read about. What is PANDAS? How does it affect your family system? Possible tests you'll do. Let's learn from these amazing doctors. With no further delay, I'm going to introduce Dr. Susan Sweeto, the hero.
This is where I wanted to come in.
Neuroscience and animation.
Forget etiology. All you have to care about is the acute onset of neuropsychiatric symptomatology. And the fact that it isn't just OCD or an eating disorder, but that they need to have 2 of the other 7 categories. ADHD, behavior change, and during acute exacerbations, choreiform movements. They're only present on the stress neurologic exam. Not all children with OCD and tics are in the PANDAS cohort. The other pieces are separation anxiety, very abrupt overnight onset of kids who can't leave their parents' side, or in many cases can't leave the home. The dilated pupils and the fight or flight reaction that so many of our kids get, hypervigilance and hyperarousal, emotional lability and irritability, laughing, crying, screaming for no good reason, behavioral regression, closer to 80% of the children have urinary symptoms, and then the short-term memory problems, toric or sensory abnormalities. These are the kids who are acutely unable to wear clothes because of waistbands or other problems. And we were able to take and correlate times when the child was having tics, flares, and see the difference in handwriting samples. Then we could also correlate those with their anti-streptococcal titers, and that's how we made the connection that every exacerbation is either triggered by a strep or after it generalizes by another infectious or immune-stimulating trigger. Acute onset OCD following chickenpox, influenza. More recently, the H1N1 influenza outbreak had a tremendous amount of PANS associated with it, and also with mycoplasma and Lyme disease. If you don't find strep, that doesn't mean it wasn't an infectious trigger. It just makes it a little bit harder to figure out what you're going to treat. So it isn't every strep infection. It's only those who have these antigens on the cell wall that look like the human host. We've talked about this as an autoimmune illness. I'm going to change that to something that's much more correct. It's a misdirected immune response. The fact that there's a very strong correlation in timing between months in which strep is ubiquitous in the classrooms and periods when children are having observable tics and behavior problems. If you do a throat culture on a child presenting with behavioral problems, including urinary symptoms, and the throat culture is positive, treated, 8 out of the 12 children had complete remission of their OCD symptoms. There are 2 categories of medical emergency. One of them is a child who is now refusing to eat, either because they have scrupulosity concerns, they feel guilty, they're not worthy of eating, fear of choking, fear of vomiting, fear of contamination. Second source of emergency is the children who have life-threatening behaviors. They have the impulsivity, irritability, and they're trying to jump out of a moving car. IVIG for those severe disabling cases, and at least IVIG, possibly plasmapheresis for the life-threatening ones. If your child has some OCD, some tics, there are many other things that we can use before we have to go here. Use the diagnostic criteria, medical workup, look for strep. We now know that children who are in at least their second episode, and many times in their first episode, like our index case, will have a positive throat culture at presentation do an adequate throat culture all the way back into the oropharynx. Many pediatricians don't know that a lot of strep infections present with headache or stomach ache and some low-grade fever. Ask them to do a workup for a urinary tract infection. When it's negative, ask them to then go ahead and look at a throat culture. We're so grateful for having this meeting, and also all of you parents, is that it's really making a difference one physician at a time. If we can educate every single physician, we can make a big difference.
Okay, now, I know that was pretty heavy duty, but it's making the point, isn't it? That streptococcal infections and many different types of infections and inflammation can actually result in psychiatric conditions. And obsessive compulsive disorder, the basal ganglia of the brain and the surrounding structures seem to be particularly susceptible to these sorts of infections. And there's a whole branch of psychiatry now that now talks about, they don't even talk about depression anymore, they talk about inflammatory disease. Inflammatory disease. And I can quote many people, dare I say it, and brag a little bit. Even my son, who now is a neuroscientist and working at the Austin Hospital, he doesn't talk about depression. He talks about inflammatory disease. Brian Leonard from University of Dublin, he doesn't talk about depression. I have seen him describing classical depression say, this is not depression, this is inflammatory disease. This whole notion of inflammation that is causing neurological damage in the brain. Watch this space, watch this space. Anyway, there can be other, I'm talking about in children in particular, but also in adults. Possible environmental causes of obsessive compulsive disorder. Well, brain injuries, once again, but also other things such as carbon monoxide poisoning, anoxia, lack of oxygen to the brain, allergic reactions such as bee stings, etc. And I've mentioned inflammation of different sorts such as the streptococcal, Lyme disease, Barbara Sweeto mentioned, and a host of others that she mentioned. And they have this effect, this damaging effect on the basal ganglia, the putamen, the thalamus and the striatum structures of the brain, which are all those very deeply centred parts of the brain. Why am I making that point, that they're very deep centred parts of the brain? Think of the brain as being like a house that's evolved over time, you know? And think of it as being like a three-layered house that's had extensions and additions built over time. Think of the first extension was just enough to live in, enough to get you by. So it was almost like a reptilian type of structure that just enabled you to eat, kill your enemies, reproduce, the basic impulses, keep yourself clean, whatever, so on. The basal ganglia, that's basically those primitive structures. Then you have the striatum, the more advanced structures that go around that, the reward structures, the things that make us think a little bit more about our environment and the world around us. And then we have the cortex, that makes us human beings, makes us capable of imagining, of wishing, believing, having religion, having myths, creating things, art, etc., etc. All that comes out of the cortex. So imagine those three layers for a start. Just going to move on to something different, but hold that thought about the three layers of the brain. Genetic causes of obsessive compulsive disorder. Some people, in fact, refer to obsessive compulsive disorder as a familial disorder. It does run in generations to a certain extent. In fact, the statistic is that if you say 1 to 1, it's actually 1 to 0.78. So there's an increased likelihood, in other words, that somebody with obsessive compulsive disorder will have parents who also have a predisposition to that. Now that doesn't mean that, you know, your genes determine what you are. There are all sorts of environmental triggers and so on that can affect your genes. But that's the figure that they're looking at. So there is something like a 0.22 increased likelihood as compared with the normal 1 to 1 that you are more likely to have obsessive compulsive disorder offspring if you have obsessive compulsive disorder. Talking about the genetic causes, is a very interesting marker, the D817 marker that I've got measured there. And why I mention about this, and I keep coming back to the basal ganglia, that with a condition like St Vitus dance or Sydenham's disease, the movement disorder, both that and OCD have an increased representation of this marker in their brains. I'm sorry, I've got to think very carefully to it. You stop laughing, Alex. I can see you laughing at the back. You think I'm stuck. I'm not. I'm just thinking of the right word. An increased representation of this marker in the brain. And what that marker does is it actually causes an increased vulnerability to, guess what? Inflammation in the basal ganglia. And genetically, both people with obsessive compulsive disorder, Sydenham's chorea, and lots of these other movement disorders have this similar marker overrepresented in the brain. I hope that makes sense. Okay, so is OCD a biologically based, now we're getting a bit complicated here, but I'll just call it CSTC, memory disorder. I'll explain that a little bit more later. Is it a memory disorder? Well, tests have shown that people with obsessive compulsive disorder have definite and diagnosable deficits in terms of memory, consistently found deficits in non-verbal but particularly visual or spatial memory. People with OCD, especially those where the symptoms involve compulsive checking, have less confidence in their memory than those without obsessive compulsive disorder. In other words, we doubt our own memories to a greater degree than do other people. Even if this level of confidence is not actually reflected in actual performance in medical tasks. So we imagine that our memories are worse than what they in fact are. Now, would this have any implication in obsessive compulsive disorder? Well, of course it would, because it would make us less likely to remember that we have performed whether we've locked the door of the car, for example, and 15 minutes later, did I lock that door? Did I lock that door? Well, not only are we less likely to remember, but we have less confidence that we actually do remember correctly anyway. And these tests are consistent. Once again, yes, I've had these tests done on me, and guess what? Yeah. So I fit into that type exactly. The worse the OCD symptoms are, the worse this confidence in memory seems to be. This may explain to some extent the repetitive nature of obsessive compulsive disorder symptoms. All right, now we get really technical. I don't want to go into it too much, but there is a loop in the brain. Remember I spoke about the three houses, the building, 1, 2, 3, built on top of each other? Well, there's something in neuroscience called the cortico-striatal thalamocortical loop. Sounds wonderful. But basically, it just means a certain circular system in the brain. There's your basal ganglia, there's the thalamus behind it, there's the cortex, the higher aspect of the brain on the outside, and there's the striatum, the sort of intermedial area. Now, what does the basal ganglia do? It's responsible for impulse control, it's responsible for movement, etc., etc. What does the striatum do? It's responsible for rewards. That's the area that's greatly activated by cocaine and drugs, and stimulants, etc., etc. What does the cortex do? Our higher functions. Will I do this? Will I not do that? Well, it turns out that there's a receptor called the mGlu5, metabotrolic glutamate receptor 5, and this dysregulates this entire system. Guess who have this in abundance in their brains? Now, what I'm telling you is actually 3 months old. This research came out in October of 2016 at Duke University. And the lady responsible for the publishment of it, Dr. Kalakokis, said that in her experience, the mice that were injected with an inhibitory agent that actually lowered the amount of that receptor in the brain within minutes showed less compulsive behaviours and became less frenetic in their behaviour too. Don't take it from me, please. Go to Google. You can Google this, biological psychiatry. There's the date, October 2016. But it is absolutely a revolutionary study, and people are talking about it right across the scientific world because of the efficacy in the treatment, at least in treating mice. I'm sorry? I'm sorry, sweetie. Oh, look, I better give you the study first of all, and it's a long one, and I'll come back to it so that you can print it up, okay, yourself, or I can email it to you. But it's increased metabotropic glutamate receptor 5 signallings underlies obsessive compulsive disorder like behaviour and striatal circuit abnormalities in mice. It's a long one, but basically what it does, what it's suggesting is in fact that these basic instinctive impulses are being overridden, or rather are not being overridden by our cortex, by our higher thinking faculties. And for anyone that has OCD, that's exactly what it bloody well feels like, at a subjective internal level. That's the bully, in my estimation. That's why this stuff makes sense. It feels right to me. I don't want to necessarily impose my prejudices on you, but my prejudices are backed by some pretty hard science here at the moment. Okay, so we've got all these neurotransmitters, receptors, neuropeptides, glial cells, genetic pathways indicated in obsessive compulsive disorder. You know, the trouble is it's a bit like a massive jigsaw puzzle, you know, and we've got bits of the picture here, there and everywhere, all sorts of wonderful pieces of study. But we can't fit it all together because it's just so complicated. The human mind is so complicated, and that's what we're looking at. So where is this neurological research taking us? And this is where, you know, science blends into philosophy, into religion and all sorts of things. It's challenging the most basic elements of what it is to be a human being. And what makes us us? What makes us have thoughts, make decisions in certain ways, feel certain things, not feel certain things, react, behave in certain ways? It challenges our concepts of free will. If the basal ganglia, if you like, is overriding our higher functions and being rewarded by the thalamus for doing so, to what extent are we in control of our own free will? I don't have the answer. I'm just saying, how fertile is this territory for research? It has implications for our instinctual responses and cultural practices. It's a neurocircuitry of thought and feeling. It's related to the evolutionary adaptations of the brain. It's the chemistry of sentience or awareness is really what we're talking about. No wonder we can't find ready-made answers to obsessive compulsive disorder. It is too deep. You're not going to get a single pill that is going to work on this. It's a huge area. You can only treat the component parts. Okay, so talking about treatments, let's have a look at them. The 3 treatments, and this is the third part of the talk, so treatments. Your medications, primarily your SSRIs or serotonergic specific reuptake inhibitors are the medications of choice. Used to be the old tricyclic antidepressants. Actually, the old anafranil or clomipramine used to be so effective in obsessive compulsive disorder. That was really what twigged people to, I was thinking, hey, there's something going on here that can be affected by medications. Maybe this is, you know, not because someone was adequately potty trained or, you know, whatever. There's some medical basis for this. The only trouble with the tricyclic antidepressants is my good friend Graham Burrows now doesn't say anymore because he's dead, but he used to say he wouldn't give them to a sick duck. And the reason you wouldn't give them to a sick duck is that they have very deleterious effects on the heart and the cardiac muscle. And people who take tricyclic antidepressants for a long period of time, particularly the elderly, can just fall over like that. They can have a very sudden cardiac arrest. So we don't use the tricyclic antidepressants so much anymore, although they're very good, they're very effective, and for some people they're warranted for medical reasons. But it's a risk you take. Any time you put a medication in your mouth, you make a choice of sorts. You know, it's a balancing act. Okay, psychological treatments. Well, exposure plus response prevention is one of the most effective, and then you have cognitive therapy, and I'll talk more about that in a moment. All right. Okay, choice of clinical treatments. It's a matter of informed choice. Your doctor telling you what's available and you feeling comfortable. Remember that each individual is unique. We are all unique in our bodies and our minds, and probably our neurochemistry too, to a certain extent. The other thing is persistence pays. That really, if you are taking a medication, you sometimes need to persist with that medication, even if it's not making you feel very well. Because it might just take another week, it might take another 2 weeks. If you're unsure though of the treatment you're getting, always seek a second opinion. A second opinion. In terms of the evidence that's available and what people advise you to do, somebody might do wonderfully if they take, you know, slippery bark elm tablets. Might do marvellously. They might do marvellously if they sit under a glass pyramid. I don't know. If that works, good luck to you. I'm very, very happy to you. But generally I would stick with the peer-reviewed evidence, the peer-reviewed scientific evidence. But keep an open mind, because there's new things coming up all the time. And remember, as I said, what works, works. Now the other chart over here is how we measure obsessive compulsive disorder, and I think that's an important thing to get a grip on too. I mean, everybody can be obsessional or compulsive to a certain extent, but the Yale-Brown measures over a 40-point system in 4 domains, obsessive compulsive disorder, from the subclinical to the extreme. Now extreme means you literally can't do anything. You know, you are so disabled through your obsessive compulsive disorder you can't do anything. And everything in between. Really, from the point of 24 onwards, you know, severe and moderate, a person should be trying medication. The psychological therapies might work to the lower extents, but as Michelle Graber, who's the CEO of ARCVic, a wonderful organisation that runs support groups for obsessive compulsive disorder, said to me, half our people are too sick to get out and to go to exposure and response prevention therapy classes, or to sit through, you know, hours and hours of cognitive behaviour or whatever. You know, if you can get an in, if you can make people feel a little bit better through the use of medications, then you can work with them. But if somebody's in so much pain they're not even going to look at you and they don't want to talk to you whatsoever because their OCD is hurting them so much, they're not going to be susceptible to cognitive therapies where they've got to think, they've got to focus, they've got to concentrate, etc. So that's the Yale-Brown Obsessive Compulsive Score, and that is used in every study. It's the gold standard in terms of measurement of obsessive compulsive disorder. And the interesting point is that in clinical settings, a reduction of 35%, a 35% improvement is regarded as statistically significant. So if you're not getting that 35% improvement, it's not much good. Okay, medication, effective doses for obsessive compulsive disorders. Well, I've basically made a list of the 8 medications currently available on the market in Australia that are used for, that are therapeutic goods approved for use in obsessive compulsive disorder. And I've included clomipramine or anafranil because it's a very good medication. I just want to point out something very quickly to you. Look at the maximums. 80 milligram a day. Look at the maximum, that's Prozac, fluoxetine. Look at the maximum escitalopram, Lexapro. That's 40 milligrams a day. Does anyone know anything about the dosages for any of these medications?
Is there all of the Prozac's or the older one where Lexapro is second generation of Chisholm?
Yeah.
So
Yes.
and it's also when they've had test-based, some people have had different types of reactions, so they've modified it.
God, you know more about this than I do. You ought to come up here and give this talk. Or we could do a dual act, maybe. Yeah, no, that's excellent. But what about the actual doses? Do you recognise anything about the actual dosages, particularly those maximums? Well, I'll tell you. The recommended maximum for Lexapro is 20 milligrams a day, what manufacturers, the pharmacists and the manufacturers recommend. Prozac, it's 20 milligrams a day. Now we've got here up to 80. And the same with all of these. You know, paroxetine, you'd start off at about 10. Look at them all. They're very, very high doses relative to the recommended, manufacturer's guidelines. And the reason for that is with obsessive compulsive disorder, you need much higher doses, Jim's smiling, much higher doses of these medications for them to be effective on the obsessive compulsive disorder than the depression. And that sort of means there's something different going on with obsessive compulsive disorder and the way these medications work in relation to obsessive compulsive disorder than depression. Because you've got to have such high doses of them. Prozac, 4 times the recommended maximum. Lexapro, a recommended dose would be 10, but you're taking 40. I take 40 milligrams of Lexapro to let you know. I'm taking much more than the recommended maximum for depression, for Lexapro. And what dosage are you on, Jim? So you're on that 250. Yeah, sounds like you're in the therapeutic range for OCD, but way beyond it for regular depression. Yeah. And if you can tolerate it, what does it matter? If you can tolerate it and it's relieving your OCD, what does it matter? Just by the way, the ones with the stars, I've put them there particularly because they are the ones that are actually authorised for children. Okay, they are the 2 that are used only by the Therapeutic Goods Association for children. But of course, any medication must be delivered to a child with great care, and the recommendation is always by a trained child and adolescent psychiatrist, not an adult psychiatrist, a specifically trained child and adolescent psychiatrist. And one of the reasons is because of this concern that the child and the adult too, the adults have to be watched too, is that there might be an increase in suicidal ideation, suicidal thinking. And that has to be genuinely watched very carefully. Once again, it's a balance, isn't it? Do you let the child suffer with a bully in their head, or do you do something about it? All right, I'll move on from that. And just while I'm saying that, that's why GPs are really not much good in terms of treating obsessive compulsive disorder, because they very rarely want to prescribe above the recommended maximum that the pharmaceutical company recommends. Now that's a very controversial thing that I've just said, and I'll only say that amongst friends, but that's the reason. They don't like doing it because they're not specialists, and they don't realise that that's the sort of dose that you need, a much higher dose than regular. I don't like it, but that's just the reality. Okay, what's the efficacy? Well, 40 to 60% of patients, and this is not my figure, this is Stanford Medical School's figure, will respond to a medication. You can't predict who's going to respond to what drug. Remember I said we're all unique? Over 10 to 12 weeks, this is why you need a fair span, up to 3 months. There's an indication that if it works, symptoms can decrease by 40 to 50%, or even 60% in patients. So remember remember what our therapeutic guide was, 35%? Well, if you're getting 40, 50 or 60%, that's really good. All right, principles of antidepressant treatment. Just very, very quickly, commencement of treatment, it either works well or it takes longer to work or it doesn't work at all. A partial response, similarly, or no response. And you'll fit into one of those three categories. But even if it works, 25%, and for a lot of studies now they're saying, well, 25%'s enough, because imagine a swimmer. This is the analogy I like to think of. If 25% of your body is out of the water as opposed to 100% of the body being down in the water, you're still better off, aren't you? You're still better off, because at least you're able to survive because your head's out of the water. You can do something. If you're that far down that you can't do anything because of your condition, even an improvement of 25% is better than nothing.
You can also, Jim, sorry to
yeah, no, please.
Because once you get some symptom relief, you can actually go to the higher
functions.
Which may be cognitive behaviour therapy, different ways of thinking, meditation.
Yes, yes.
But as I said before, without being able to actually get out of the door, you're not going to get it.
If you, a very wise teacher once said to me, because my background's in teaching, he said, listen son, if you can't keep those children in the seats, you can't teach them. It's a similar analogy in a way. If you can't get the patient outside the front door, you can't do anything for them. So first you've got to get them well enough to get out the front door. And this is exactly the point that Michelle Graeber was making at the OCD Foundation. It's all very well for people to say, look, you know, I've got this wonderful cognitive treatment, etc., but you can't get them out the front door. They're not well enough. Okay, antidepressant side effects. I probably don't need to spend much time on that. I'll talk about the benzodiazepines. Anyone interested in the benzodiazepines or not really? Yeah? Okay, look, the benzos are really an important medication in the treatment of OCD. There are the basic benzos, and there are the dosages that are often prescribed. The two most effective, personally I've found, have been Rivotril or clonazepam, or alprazolam or Xanax. And you can see pictures of them. Now, which of the two is better? Well, I find that they really have a very different effect on me if I take them. Alprazolam is like putting on a pair of sunglasses, quite frankly, and that's the best analogy that I can use, that it sort of, it dulls not your cognitive faculties down, you can still think as well, but it sort of dulls your senses down a little bit, in the sense that it's like blotting out the sun a little bit, making the glare go away. It's a little less, the world is a little less vivid, etc. Alprazolam doesn't seem to have that effect. Chemically, alprazolam is much shorter acting, works more quickly, shorter acting, doesn't last as long, and doesn't have a similar feel about it, but is very good for making you sleep. So that's a very big positive about it. Clonazepam, that's prescribed to treat seizures, disorders like tremors, interestingly used in Tourette's syndrome, once again, keeps coming up, multiple sclerosis, all sorts of conditions, spasticity, very commonly used in spasticity. Side effects, well, all of them create a drowsiness to a certain extent, a certain clumsiness, fatigue. I don't agree with confusion, but perhaps after you get, they do make you tire more easily, so maybe you could say confusion, yes. Memory problems, slowed breathing, that's certainly true, your heart rate slows down, etc. And they say addiction, well, I'm not convinced of that. I mean, I've been using clonazepam for 35 years, you know, and one of you being a wit might say, well, if you've been using it for 35 years, you're addicted. But I don't see it that way. I mean, I don't use it all the time. I might use it, you know, once a fortnight or once a month or whatever. I use it PRN as needed by myself. I don't think that's addiction. But if I need a pair of sunglasses, I'll take a tablet.
Have you ever tried Buspar?
Buspar, no, I've never tried that. No.
Because that used to be prescribed in the 90s, and it was in the PBS, and
Yep.
it's been taken away, and now it's $100 a bottle. So it's just got come away from the PBS, and Buspar was prescribed for OCD back in the 90s.
Yes.
And now it's not.
And this is, and you've anticipated a point that I was going to make and am going to make, that to me, as a sufferer of OCD, I want every weapon in the arsenal that I can get. Because as Freud said, and as J.J. Keeler said right in the beginning there, this is one of the most vicious, nasty, unpleasant conditions to live with. And I don't exaggerate that. I say that, and we've got people that meet with people with all sorts of conditions, but the inner torment that OCD causes for people just leaves me staggered, quite frankly. You need every weapon in the arsenal, and I resent, as a consumer, any weapon being denied to me. You know, give me a stick, give me a stone, give me a plastic bag if I can use it, you know, to battle this demon. But alprazolam has been banned. It's been rescheduled as of, when was it? As of very recently, 2014, September 2014. Now it is scheduled with drugs like the opiates, cocaine. It's a Schedule 8 poison. Not allowed to take it. That's alprazolam, not clonazepam, which I take. So they've given me one of the two now. One is gone. Now I only have one left. Like your Buspar, you know. They've taken it away.
Sorry, just with the benzo, that's with the battle, is with the doctors. Some will prescribe benzos and some won't.
And quite frankly, as someone who we're starting a new OCD support group at the foundation next Tuesday, and you can get our brochure, and please come along. Anyone who is interested in coming along, you know, we discuss issues like this, you know, and there's great debate amongst doctors as to what they will prescribe and what they won't prescribe. But once again, psychiatrists are more likely to prescribe it because they understand. Okay, this is just a case in point about the psychological therapies, and I've listed some of them for OCD: behavioural therapy, cognitive therapy, interpersonal therapy, mindfulness-based cognitive therapy. That's a nice one, isn't it? What a mouthful. Acceptance and commitment therapy. There are all sorts of therapies that are available. But I have to tell you that the evidence really is exposure and response prevention is the most effective. You're smiling, but I take it you think I'm right or I'm wrong? Okay, I'm not asking, it's all right. But the exposure involves exposure to a situation or object that triggers the fear or the anxiety. Over time, the anxiety generated by these obsessional cues decreases if you're exposed to them. And what a psychologist will then do is, over time, gradually in a systematic way, prevent your response, prevent your way of dissipating the anxiety, whether it be through cleaning or whatever. And I'll give you some examples of that, if I can get this thing to work. Oh, here's where it intersects in the line. You've got the intrusive thought or obsession, you've got your anxiety or distress, and then, okay, you're not allowed to deal with it, and then, you know, don't deal with it, accept it, and ultimately over time you'll feel better. The big problem with this is not a lot of people with OCD really want to go through that kind of hell. They can, but for example, if you had to, you know, spend 3 hours with your hands like that and you suffered from OCD, not that you'd spend 3 hours straight off, but even, you know, 30 seconds with your hand like that, hands like that for a person with OCD. That would be a terrible distress. And we can even have a way of measuring that distress, which I'll mention in a moment. You know, not being able to check that you'd locked those doors for 5 minutes, let alone 3 hours. Having to sit and watch a set of pencils like this that were not symmetrically aligned, not being able to check the gas, allowing an insect or a spider or something like that. So I just threw that in there because a lot of people who don't have OCD have fears of this. Well, imagine having that crawling up and down your body for 5 minutes, let alone 3 hours, and you get some idea of what it's like for a person with obsessive compulsive disorder to experience some of these unpleasant situations. So let's have a look at these subjective units of distress, as they're called, or SUDs. Putting mail in a mailbox, but you don't open to check that you've actually put it in. That might be 25 units of distress. Unplug the iron, leave the room without checking. That might be 30 units of distress. And here's the distress thermometer, the subjective units of distress scale. Okay, so we start off with someone who's totally relaxed, which means they're unconscious or semi-conscious, and then they're alert and awake, concentrating well, minimal anxiety or stress, then mild anxiety, distress, no interference with performance, and that's probably a very healthy way for people to perform tasks, challenging tasks in that kind of range. Probably most of us would like to be here, minimal anxiety or distress most of the time, and most people would be, but we fluctuate between there. Then you start getting up towards the 50-point margin, moderate anxiety, distress, uncomfortable, but can continue to perform, but only with great psychic effort. And then up to the 70, 80, 90, 100. Imagine 100 units of distress, highest distress, fear, anxiety, discomfort that you have ever felt. What would that feel like? What in your life have you experienced so far that would lead you to feel that way? I don't know, but that's how we measure it anyway for obsessive compulsive disorder. Cognitive therapy, CT, look, I don't really have an opinion on that. Once again, it's very cerebral. It's very intellectual in terms of how you understand it, etc., etc. The research that I've done as far as cognitive therapy as opposed to cognitive behavioural therapy, which is a combination of cognitive and behavioural mainly being, say, exposure and response prevention. Cognitive behavioural therapy can be very effective, but cognitive therapy on its own, I don't think so. I don't think it... Certainly the studies recommend cognitive behavioural or simple behavioural therapy, you know, like exposure and response prevention. And I would certainly vouch for that. But many of the other psychological interventions are very much untested. And I've recently been doing a lot of reading about, for example, one that really appealed to me a little while ago, and that's the mindfulness-based cognitive therapy, because everything's mindfulness now, isn't it? I mean, we all talk about mindfulness therapy, etc., etc. And what is that, etc.? Well, without me going into a detailed explanation of what I think it is, I've looked at the literature going back for the last, 5-6 years since the concept of mindfulness has been bandied around, and there doesn't seem to be much effective research being done. All the studies that I've seen to date come out with the conclusion this may have some benefit, however the studies are too small and there needs to be more research done in the area, etc., etc. So I make no comment about that. All I say is that the research is just not there, and we can't really form an opinion. All right, thought suppression. Okay, who can suppress their thought? Can you suppress your thought? If I say, don't think of a dancing pink elephant in a tutu, can you not think of that? No, no. For many years this was a belief that thought suppression would work with obsessive compulsive disorder. But as soon as I tell you don't think of something, guess what? You think of something. And the first person that I heard to point this out was Professor Michael Curious, who was professor at Swinburne University. He said, this is a ridiculous notion for people suffering from OCD, because as soon as you tell them, now, I don't want you to think about that thought, as he said, people with OCD don't have that capacity. If you tell them not to think about something, that's the first thing you're going to do. So he was very critical of that 20 years ago, and I don't see much to do with thought suppression. However, one form of thought suppression does tend to work with OCD, and I hate to say it, and that's pain infliction. So if I tell you, don't think of a pink elephant, and you say, I can't not think of a pink elephant, and I go up and I pinch you fiercely on the leg, and you go, ah, guess what? The pain overrides the pink elephant, doesn't it? The basal ganglia response overwhelms the cognitive, which is a pretty good indication of what obsessive compulsive disorder seems to be all about anyway. You know, the primitive impulse overwhelms the higher cognitive function. Okay, and once again, you know, I just like this because it's a nice mocking way to end on that one. Stop that, right, stop that. It's very silly indeed. It's very silly. The point is, we know the thought is silly. We understand that the thought is silly, whatever the thought is that bothers us with obsessive compulsive disorder, but that's not the point. We can't help it. We can't help but be tortured by it. Now, another treatment is transcranial magnetic stimulation that is having some success, especially in depression. And as I've got up here, the latest research is from the Alfred Psychiatry Research Centre at the Alfred Health from Professor Paul Fitzgerald. And the study cites that 1 in 2 people respond positively, and this is for depression, remember, depression, not OCD. A study of 1,100 people who received this type of stimulation, more than 500 benefited, according to his measurements, which is pretty good. All those patients had not responded to traditional medication, its big benefit is that it's a non-invasive treatment. There's no medication, there's no injections, there's no having to turn up for hours and hours and practice, exposure and response prevention, or thought stopping or cognitive therapies. The dropout rate for people was a fraction of those even undergoing medication. And currently being investigated is whether TMS can be used to treat a range of other conditions, including post-traumatic stress disorder, OCD, as I put in red, Alzheimer's disease, and others. So it is a hope for the future, put it that way. It is a hope for the future. But I have to say, on reading the scientific literature about transmagnetic stimulation, the studies are not particularly of benefit as yet. There's not a lot of studies to say this is great and we really must do much more of this because the evidence is thoroughly there.
You've actually got a couple of people that have actually done TMS for Victoria Clinic.
I'm sorry?
You've actually got a couple of me and my friend here, we've done TMS for OCD at the Victoria Clinic.
Right. How did you find it?
Part of the study, we didn't find it.
We didn't find it effective.
Okay.
Yeah.
Okay.
I've had
Yeah.
60 sessions of it through 20 inpatient programs. We found 2 weeks at the very tops of moderate success, but by the first week it started to drop off rapidly, and apparently there was others that had months worth of success, hence why they stopped my treatment. But even then, it was a very small percentage of people that were getting the theta burst for the TMS were getting any benefit at all. So
Right.
it's not surprising that I've met numerous people, including Michael, who have had little success as well.
Thank you very much for that, because just by the way, I know that there are people in this room that are going to undergo this treatment very shortly, and that's great to have that kind of feedback.
There has been people, I've had a friend from Adelaide who's come out of Victoria Clinic to do it, and he gets months worth of success. minimum of like 4 months, which is amazing. So it's not to say it doesn't work completely,
Yes.
but it has so far had no effect whatsoever.
Okay.
I think the trial group is 60 people too.
Okay,
So
okay.
I think they've only got about...
So it's in the early stages, and look, there might be all sorts of reasons for that. They might not have targeted the right area, they might not use the right intensity of magnification. I mean, it's like a medication. You've got to get the right dose, the right time, the right length of time, blah, blah, blah.
The trial really looked at the guinea pigs and there was no real guarantee of any success
Yeah.
whatsoever.
Yeah,
They did
yeah.
try a few different areas in the brain and
Yeah.
different calibrations
Yeah,
and stuff.
yeah.
So I still have hope in the possibility of the future of it being successful. And
Yes.
like the TMS use for depression is more successful these days, and I'm
Yeah.
sure that back in the day of the trial process for that, they had a lot of unsuccessful.
Because it does work for
patients
mental depression.
For depression, but not the OCD.
Yeah,
It's fascinating, isn't it?
One of the major issues with the TMS is that they can't get very deep into your brain. So if it's issues with, say, the basal ganglia
Yes.
or the striatum,
Yes.
it's difficult to stimulate those areas
Right.
with the TMS
Right.
cord.
Right.
They're working on cores that can
They
get a
have a
little
new
deeper.
machine that's
If I'd known there'd been so many people in here who knew so much, I would not open my mouth.
The
You know.
new machine that they're using specifically for the OCD trial, that's a burst machine, and it only requires 40 seconds to let it get a minute wait, then another 40 seconds of the bursts, instead of a 40-minute like the one I'm getting for depression currently. And I do feel it does hurt a lot, significantly more, which maybe is a reason for the fact that maybe it targets deeper into the brain.
Right.
But I'm just thinking that maybe that's contributing to the fact
I would love to-
that trialing for different part of the brain
Yeah.
is further down.
I would love to talk to you for quite a long time about this. If maybe you would grace us with a visit sometime at the foundation to one of our support groups. Okay. Anyway, sorry, because I am rattling on a bit, but I'm just about there. How long have I gone? Oh, an hour and 20. Not too bad, I guess. All right. Oh, I should go back. So let's just have a little bit of fun. All right. OCD test. Put up your hand if that bothers you. Oh yeah. Well, usual suspects. No? Okay, that's interesting. Okay. What about this one? That one? No? Usual suspects. Okay, well just keep calm, because I'm ordering tonight. That was supposed to be a joke that I was going to end with, but that went over like a lead balloon, didn't it? Okay, I'm sorry. Thank you very much. That's me done for tonight.